thank you very much for the introduction. And yes, I am Swedish. I live in Norway, so it's going to be multinational perspective here. Thank you for inviting me to RAMSES. And like I said, it's going to be a little bit of a multinational twist to this presentation. I have worked in 6 different countries in 2 different American states, so I hope to bring a little bit of that perspective into this. Let's see, doesn't want to move. Like that. All right. So my background is that I'm Swedish, and I did my med school in Sweden, and after that I did my internship in Norway, and after that I went to the United States and trained with Dr. Sandberg, amongst others, and stayed for 8 years in the US. And then I went back home to Norway, and I've started a program for microsurgery for lymphedema. So my next step is going into robotics. So when I chose to go back, I chose to go to Norway, and multiple reasons for that. If you look at quality of life scores, almost all the polls show that Norway is the best country to be. Except for that, we also have socialized medicine, but not socialized medicine without funding. We actually have a lot of funds, a lot of oil money, and we do have socialized medicine in the sense that it can be some amount of red tape, but not at all as much red tape as in Sweden. So that's why I chose Norway. And I went to a hospital that's university affiliated. The reason for going there to like a slightly smaller hospital was there are less people to deal with if I need to innovate or introduce something new, and there's less competition for funds. So we have a urology service and gynae service that uses robot. Colorectal service is not using the robot yet, and we have a Da Vinci S robot for now, and we're about to upgrade to an XI pretty soon. So we're all sort of walking and making our paths as we walk along. I think that despite all these different systems that I've been in, I can see that there are similarities when it comes to opportunities and obstacles. The way that I look at it is that there's government and administration, there's department culture, services and referral cultures, and there's work culture, industry support. All of these things are going to affect your access to a lab, your access to the robot, access to OR time, and also your grassroots support. In Norway, they have a standardized method, process for introducing new treatments and procedures. It's called a mini method evaluation. You have to probably work for 80 hours or so and make a 360-degree evaluation, and that's pretty much the basics, and that will be evaluated. Government will require some training. Obviously, for plastic surgeons, there are not so many sort of certificates that you can have, but if you can show that you have an intuitive certificate, if you have actual training both in robotics and laparoscopic surgery, and if you have some references, that will always help. In Norway, we have the DRG codes, and for performing robot-assisted procedure, we get 58.6% added refund. For me, it's very important with the department culture. I think that is a lot of times where in Scandinavia we'll meet sort of the most resistance. So I pretty much went to the most innovative place in Norway where microsurgery was actually started in the deep flaps. And we have a way of thinking ahead. My chairman is also trained in the United States, so we have a similar way of thinking. When it comes to production, and that sometimes goes against your innovation, so there has to be a balance, and I think at our department we've met that pretty well. So work culture is very, very different in Scandinavia from other countries. Maybe that's why the quality of life scores are so high, but all good surgery is usually done at 3:30 p.m. And you have to really help out with your staff and make them sort of feel part of this and get a grassroots movement, get people engaged in what you're doing. When it comes to service and referral patterns, I think that's very important for what you can offer as a plastic surgeon in robotics. Unfortunately, at our department, or at our hospital, we have a very poor history of collaboration with general surgery, and that's a little bit of a downside. So, let's see, I don't know if you can start the video there. So one of the things that I did when I came back home from the United States was to do a video. I'm not quite sure if you're going to be able to start that. Maybe, maybe not. So I think just like Dr. Sandberg said, I think a picture says more than 1,000 words, and it's important to be able to show what the possibilities are, what you can do. And this movie that I recorded was, well, pretty much a bit of a struggle because I could only access it during nights when there was no one using the robot. And so I did it when I was on call, so in between calls for Tylenol and could that patient get an enema, I was like trying to finish these anastomoses. And if we get it started, you'll see that there are multiple anastomoses done that I had to interrupt just nearby. So it's pretty much the same model that we used at MD Anderson for training. I did not have an assistant, so I used the 3-arm approach on a 3mm vessel, and I think this is something that I will use also in the future for the administration, show what I can do. This was pretty much like my first trial when I came home to Norway, and I had to pay an immense amount for importing that first silicone tubing. We later resolved that, but so I did many anastomoses on the same vessel, like just a couple of centimeters away. So very sentimental value, this video for me. And like I said, it's important to be able to show something, what you can do, what the potentials are. And I've had great help from my local representative in getting instruments, getting contacts with labs, getting connections with people at different hospitals. So I think it was well worth doing it. It doesn't take very long. This is obviously at 4 times the normal speed, otherwise it would be a little bit like watching paint dry. It takes 12 minutes. So I think that's pretty much the editing part of videos that Dr. Sandberg talked about. You have to sort of speed up things there. So we'll just cut to, let's see. So my first choice was where to practice, and I chose Norway. Second most important choice, I think, when you're introducing something new is what type of procedure you're going to use. And when I look at procedures, I look at volume, and can you be assisting other services without cannibalizing their OR time? When I came back from the United States, this is a cultural difference. People describe me as very cushy and forward, and I'm not sure if Dr. Sandberg would agree with that. I think, no, of course not. As a Scandinavian, I try to avoid all confrontations, and for me, I don't want to cannibalize the OR time, and we have a robot that's not being used all the time. Also, the specific Norwegian requirement that the OR time should be done at 3:30 p.m. because then you need to go out and go skiing. If you can do shorter procedures, then that is a benefit. And preferably to avoid on-call procedures. Looking at the VRAM, I think that's an excellent operation to perform. It's a proven concept, fairly straightforward. And if you have general surgery training and laparoscopic training, you'll feel very comfortable performing it. It's minimal invasive with obvious benefits. obvious need, it has a volume, but you need referrals. The LD is also a proven concept. It's minimal invasive with benefits. No need for referrals for this, so that's also a good procedure to perform. My primary goal is to start doing lymphovenous anastomosis with the robot. I think the concept is ideal for robotics, and there's no real need for referrals from other services. Of course, there's development going on with the optics and the instruments, and I'm looking forward to seeing some of the developments here next few days. And in Norway, which is a reasonably conservative society when it comes to surgeons, the acceptance of LVAs has to be proven, and I'm doing that right now with a straightforward super micro approach. So getting robot time, what I've done is that I've cooperated with other services. In Norway, plastic surgeons still do resections for malignant melanoma, and I've collaborated with iliac lymph node dissections with the urology department, and I think a lot of it is working together with different services. So I think it's important to be part of a team, at least in the beginning, and it's good to take part of any procedures that are robotic and to be part of the team. To have like a grassroots movement is very important. You have to get the staff involved and interested in what you're doing. And also it's important, if you're going to do things on call, get training from the nurses and help them out with setting up and stowing away equipment. I think helping out sometimes is a bit of a bother, but you do get that back. Sometimes I feel a little bit like a glorified janitor, but it actually works, and I get to do my lymphovenous anastomosis, and I've started up that. I think it's important to make it an exciting experience for the team and include them, and I think small places with dedicated staffs are excellent. I think also when it comes to the setup, try to team up with a robotic service nurses to make the plastics team more comfortable. And if you are doing a case that's not multi-speciality, you should get the rep there and the robot service nurses. The way forward on my path will be pretty much to go back to basics and reinvent the wheel. I'm going to do some animal labs, a little bit for the proof of concept, and show my colleagues what is possible. I'm hoping to go into doing LVAs and robotic LVAs in the future. I'm also considering doing some nerve repairs. So that's pretty much it. Thank you.